screen turned off.
Yeah.
There we go. Okay. All right. So, Darin, would you like me to do an introduction for you? Or would you like to do it yourself?
I can do it myself. I really appreciate that.
Yeah, absolutely.
Okay. Well, thanks, Jonathan, and good morning, everyone. I'm Darin Challacombe. I work for Verisma Systems. I've had Jonathan do the introduction, but there's normally a bio that's sent along, and it's probably like 3 or 4 paragraphs, and it talks about how I can walk on water and stuff. And I don't really like going over that, so I thought I'd just do the really quick and simple. So I work for Verisma Systems. I'm our director of talent development, so in the HR space. So I know that primarily there are some students involved in the audience, and even those probably aren't students right now, but we are always looking for great individuals that are working in the space. So if you're ever interested, you're welcome to reach out to me, or you just visit our verisma.com website and look for some positions there. So we have quite a few remote positions. I work remote out of Kansas City. So that's what that's that. I wanted to, we're going to be talking about the role of health information professionals in the social determinants of health space. If you're in, I have had the opportunity to speak at this particular conference before, and I get the impression, and I'm from other conferences across the country too. I get the impression there are a lot of people that are involved with in the national space with the AHIMA, or the Health Information Management Association, or their state one. Obviously, the state one there in Washington they do a really good job of producing great speaking opportunities and learning opportunities for its members. But I'm not sure how much visibility you have into what AHIMA at the corporate or at the federal level, what national level does. And they've been AHIMA has been really focused recently on SDOH topics, social determinants of health. They've been they put together, I believe, at least four conferences, not conferences, but meetings, long day, like one day meetings or so over the last year at least. I'm very fortunate for my job that I have the opportunity to do some research, and that's been something that's been really helpful for me. So my background is in, I have a doctorate in psychology. I enjoy doing research, and over the last 8 years, I've gotten the opportunity to kind of go into doing research more and more in the SDOH space, and so that's kind of my background behind here. So as we go through in the next few moments, I'm going to be talking about some of the research that I've had the opportunity to do, but I did want to put that plug in there for not only your Washington Health Information Management Association, but also the American one, or the national one, on that they're operating in this space as well, and there are opportunities to continue learning if this is something that maybe you're interested in learning in the future. So this is our agenda for this morning here. We're going to talk a little bit about what the current research is, and in this space, we're going to be more specific, kind of talk about Washington State to some degree. I'm sorry, Jonathan, I made some changes to this slides even as of early this morning to add in some Washington State specific statistics, because I think it's important for all of us to just kind of have a view of like, oh, what's going on for me. It makes it more visceral and more real for us. We're going to talk about some different indices with that, and then we're going to go into food and financial insecurities. Both of these are topics that I've had some opportunity to do some research, and I'm going to talk a little bit about that, and kind of how, what is our role. We're going to talk a lot about health literacy. Basically the ability for a person to understand their medical records. Obviously, as us in the health information space, this seems to line up one of the best, if you're looking at things, one of the best lineups with what we do in health information, and what we can impact or influence for change. And then we're going to talk about some suggestions from here. So before we get going too far, I have a Slido poll. I'm not sure if you've done one of these before, but I'm going to ask you kindly if you take out your cell phones. I'm sure probably some of you already have them up, but if you could scan, and I'm not sure how this is coming across, but if you can scan the QR code in the upper left, it's going to prompt you with this question here, which is, what are social determinants of health? And so I kind of want to see what your thoughts are. Again, this is a safe training environment, no right or wrong answer. Just kind of want to see where everybody is and what your thoughts are on this. But the question is, what are social determinants of health?
All right, we've got an audience of people pulling out their phones, so
That's great.
we'll hopefully get some good response. There's the furious sound of typing on a silent device.
Okay, so what do we have? What you've typed in so far, and it looks like maybe one or two more people are typing in, but we have finances, culture, work-life balance, routine, the social factors that influence health, the real world where you live, and challenges that come with the extra things that influence the ability to be healthy. I like that. Potential barriers to optimum health outcomes, knowledge. Yeah. And then we have some, or it looks like we're putting in some individual ones like circumstances, socioeconomic, persons, things. Yeah. So it seems like you all have a really good handle of this. So I can finish my conversation. We'll end the presentation right now. No. Great. So that's what we're going to be talking about. I want to start out by kind of talking about these areas where, and let me turn my phone on to vibrate. Sorry about that. Some of the areas where researchers have focused on these over the last, over the last 20, 30 years or so, that the theory behind here. So again, these are the ones you normally hear about, like food and financial. We'll be talking about the housing, transportation, education, employment, and social support. And there are other factors as well. So I didn't see this necessarily on the previous slide with some of your responses, but there's an area called social capital. If any of you had the opportunity to attend it was Advocacy Day or advocacy, yeah, the time once a year. I think it was in February of this year in Washington, D.C., where HIMA put on a advocacy conference or summit, basically, where the first day was prepping for it and the second day was actually meeting with your elected officials. But on the day that they were prepping for it, they had somebody from Press Ganey come in and speak about social capital to some degree, but social capital, that's another avenue there. But basically, somebody put it succinctly on the previous slide. When I think about social determinants of health, I think about those other factors that influence healthcare. Obviously, providers, everyone in the hospital health system, those are factors there. Those are things for the most part, we can control. It's the other things, though, that we can't control about where a person's environment, they're living, they're growing up, family, lots of other things that influence how they perceive that, even, their perception of healthcare in general. So we're going to talk about that to really kind of get to the point of better understanding the needs and then try to address them. So looking from, and I was able to put these together last night. So pulled from a couple different sources for this, but for SDOH statistics in Washington State, most of these came from the Washington Budget and Policy Center, the University of Washington, and Washington State University's WA or Washington Food Survey, and then the Washington Health Equity Office. All of this is from 2024 to 2025 data, so relatively recent. On the first one, about 10% of Washington residents live below the poverty line as of 2024, with 137,000 residents at risk of losing SNAP benefits due to federal work requirements. The horizontal bar chart shows really food insecurity rates by group. households with incomes under 15,000 face an 82% food insecurity rate, followed by Black households, Hispanic households, and households with children, and then renters. Um, while if and we'll probably talk about this on another slide, but Washington State is actually one of the top 10 for having for as far as quality of life and having I guess the least top 10 least impacted by food insecurity. So obviously when I go to states like where I live in Missouri or spoke at Iowa on this, they're quite a bit lower than your state as far as they have more challenges with this. But that being said, these numbers are sobering because these are our neighbors. And then on this, we talk about some of the uninsured rate disparities. Overall, about 6.5% of Washington residents lack health coverage in 2024. Some other races, they identified themselves as being about 22.9 or 23%, more than 3 times the state rate, if you will. Hispanic and Latino, and then American Indian and Alaska Native residents were uninsured at roughly twice the overall rate. And then when you look at the racial disparities in poverty rate, again, you can kind of see from below, you have the state average about 10% here. I'm sorry, there you go, 10% here, and then you have the white, non-Hispanic, Asian, and then on the other side of things, with greater disparities in poverty rate, you have the Hispanic, Latino, and then the American Indian, Alaskan Native here. So the need is there, and there's probably we could spend another 10-15 minutes if we had more data points to look at, but there's obviously a need, and I think most of us can see this depending on where you live. But you drive down anywhere. I've had the opportunity to visit your wonderful state multiple times, and I just know that there, as I'm driving different places and stuff, you're going to see people that are suffering from housing insecurity, and probably individuals that are suffering from food insecurity. You can see that more visceral. You may not be able to see whether they have insurance or not, but it's still one of those things too. A lot of that we can actually see. I love Brene Brown for some of the things that some of her thought leadership, and in here she says that every statistic you see is someone's mother or father, sister, brother. So data has a better idea, data has a soul, and I like to kind of keep that out there because I think it's important just to kind of put a bow on this discussion as far as looking at state level statistics on why the need is there. So we're going to start by talking about food insecurity. So as I mentioned, and kind of as I kind of went into a little bit, so the 2024 rate of food insecurity in Washington was 11%. It's a statistically significant difference from the U.S. average, even though Washington ranks among the top 10 states with the lowest rate of food insecurity. The situation is far from ideal, and the numbers on the rise. So with food bank demands, Washington residents were to food banks 13.3 million times over the 2024 fiscal year. Again, these are statistics, so take it for what it's worth there. But that's up from about 10.9 million visits the year prior. In terms of total state population, 1 in 4 Washingtonians went to a food bank in 2024, a rise from 1 in 5 in 2023 and 1 in 6 in 2022. And that represents a staggering 70% increase in food pantry visits since 2021. Now, I want to talk. So with this, some of the research that I've done, and I'll kind of talk about it as we go through here, but it's really fully understanding the idea between what a food desert is and what the new term that you may have heard of, which is called the food swamp. So we'll start with food desert because I think most of us are familiar with that term. But food desert, depending on how you're looking at, the government defines it as being it's somebody who lives outside of 1 mile from a grocery store if they're in an urban setting. If they're in a rural setting, it's more than 10 miles. That's kind of how that looks. In Kansas City, we have historic issues. If any of you have visited the city before, you may not have, like everybody likes the city and stuff. But if you were to look at background behind it and visit some of the areas, there's just historic racism that existed, and so because of that, the racism and some of the laws and stuff from the past that kind of put up dividing lines within the city, there are areas that are food deserts, even within like that yeah, there's some significant there's challenges there. You go across one of the streets here in town, even to this day, even though it's illegal to do this and that, but even to this day, if you go across one of the major streets called Troost, you kind of get into this area of a food desert, and you're looking for you're having to drive more than a mile to get to a grocery store with fresh fruit and vegetables. And that's going to further increase. There was a grocery store that was developed out and kind of supported by the city for a while, and then they left about a year and a half ago, and so it's looking like they're going to build another one or going to put another one in. But the individuals that live on this side of the city are ones that they hate. If they don't have a car, they're having to get on public transportation and having to do that. And even with that, our public transportation locally is we've had issues where, well, for the last 10 years, I think it's been free. And then just starting a week ago, because we lost funding, we've started to charge for public transportation for somebody to ride the bus. And so these individuals that live in this part of these parts of town that don't have access, they live in the food desert. Plus, they also are now having to pay for getting on a bus or so. The bus systems are it's okay, but it's not the best. So there's a lot of challenges there. So you can imagine why, just from my local perspective, there's a lot of challenges with this. So what I wanted to do is look at food deserts. Now, food swamps, on the other hand, are areas where where you do have access to fast food and to convenience stores. So like a gas station, if you will, or Walgreens or CVS. Most of the Walgreens, CVS, Dwayne Ready, or whatever you have up there in the Pacific Northwest. You're going to have most of those, or at least the ones around here. You might have a banana or something. You might have some fresh fruit you can buy, but you probably have access definitely to milk, to eggs, to some maybe deli meat or something that's in the freezer section. But again, you don't have a whole lot of options, so you're having to just use whatever you have there. So that's what a food desert or a food swamp is. So food desert, food swamp. We kind of giving you a perspective from the state itself here. This is where things are, where the reds are where there's a high food desert rate or risk. The lower, so like the pink or the lighter color reds are the moderate food desert rate risks. Food swamps are the dark greens, and high food swamps are the dark greens. Moderate food swamps are the light greens. And then both deserts and swamps are the blues, is how I done here. So risks for both deserts and swamps. I had the opportunity recently to look at national statistics in this space, specifically about food deserts and swamps, and I was looking at four major health issues that people have. So I looked at obesity, diabetes, high blood pressure, and mental health are the four that I was able to get data from. And so again, I'm looking at nationwide data, looking at different census tracts, but I was able to find, I just ran the statistics. I don't have it written up, but I was able to find statistically that individuals that are in food deserts and swamps, which aren't a whole lot, like in the greater things, across the whole United States or so, we're talking about census tract, less than 1% of census tracts are considered both deserts and swamps. So, that's not a big, but for those individuals that are there, it was twice or even more, greater than twice the national average for having issues with diabetes or obesity or mental health issues or high blood pressure. So that tracks with what other statistics have shown, that individuals that live in these areas, they're going to have greater concerns, because if somebody does have an issue with, say, high blood pressure, and they don't have access to go to buy fruit or vegetables that are even that are good for helping with that, or helping to sustain or moderate that condition, then they're going to buy whatever is convenient for them. And if their fast food is the only thing that's convenient, McDonald's or what have you, if that's the only thing convenient for them, they're gonna do its best for them. That also goes with, this is another topic, but it also kind of goes into the price for things. I think all of us have seen definitely an increase in prices, but if even before, or even the last 10 years or so, if you were to compare the prices for, for $5, I can buy a lot of junk food. Definitely, I can go to a store and buy a lot of junk food. But for $5, I might be able to buy a a bag of salad or something like that. I mean, depending on where you go. So you're limited by what's out there. So I just wanted to throw that out because I think this is something that's really important. I know one of the colleagues I work with, she was the HM director for a facility in the Philadelphia area. She used the data points that she had access to about the folks that were living around, the patients that were living around her facility, the ones that were coming in. She went and used data points to basically provide support for and get some funding from the facility. And again, this was years ago, but get funding from the facility to open up a food bank within the facility. So it was once a week. They would, from 10 to noon or something like that. They would be able to offer, have a food bank. One of the things that I really like about there's a lot of great things that there's a lot of great organizations in the world. I'm sure it's the same there in Washington State, and they do a lot of great things overall. That a lot of people are trying to help out in different areas. One of the challenges with this is the fact that many of them don't communicate with each other, and so you run across issues where somebody doesn't know what services are available, or they may know about this food bank, but they don't know about these other 5 food banks that are open other areas. In Kansas City, it's the same thing. We have, depending on what day of a week, there's meal service available at like in community-wide meal service areas. And if you don't know, if you only know about the Monday service that's there and at this church, then you're missing out on the other days of service. So it's kind of getting to know what those spaces are. So even the individuals that are having to deal with other things like food insecurity or housing insecurity, they're having to navigate all these different great organizations that are out there that are doing great things but aren't communicating and being able to share the information. So if anything, one recommendation, I think I'll talk about that later on, if you're able to take this back, is to just make sure those patient-facing people that are working in this space, that they have a list, or you can put together or help put together a list basically of the access points for individuals that are dealing with food insecurity, where they can get access if you're not able to do something from the facility itself. So that's the first one. The second one is on financial hardship. So we did something a little different here. I haven't done nationwide research yet onto this. It's one of the areas I'm going to be doing some work on. But what I wanted to look at is I wanted to look at internally for Verisma. We work in the release of information space, if you're unfamiliar with that. So I used data from 2022 because I wanted to go back a couple years where I had some nationwide data to use and want to get something too recent. And I went through and looked at the requests that came from patients. So if you're familiar with release of information, we have a lot of requests come from patients and from other sources, but with patient requests, we code them differently because we don't normally bill for patient requests. That's generally not what, if we do, it's a nominal $6.50 fee or something. We're not making money off of providing records to patients. That's not something we do. But with that, we code it differently because of the fees and other things like that. And so what I did is I went through and looked at those requests that were coded as being patient requests. And for those that I actually were able to code where we mailed it to the patient or put in an address for the patient, I looked at those zip codes. And so I pulled a list of the zip codes of the ones that we had sent to in a period of time in 2022. And I went through and looked at the zip codes of the most common or most frequent zip codes. And then I took that information and I looked at financial data from the American Community Survey or the U.S. Census, and then also from the IRS. So both of these are data sources you can get. I actually used them when I was talking about the previous study where I was looking at food deserts and swamps. I used some data from the IRS and from the ACS, or American Community Survey, for that study as well. But these are data points you can get actually pretty easy to get onto. And so if you're ever interested in doing that, you can filter down. One of the challenges with, I think it's the census data, it's looking at census tracts and not necessarily zip codes. So you have to marry those up a little bit. So it's a little finagling, but you can get some of that. So there were, as it says on the screen there, from what I was looking at, I looked at 125,000 or 126 basically thousand requests. And then, came down to the ones where the patient, the requests for addresses were the same. So about 121,000 is what we ended up with, and then use that data. These are the zip codes that the kind of the top zip codes. I'm not sure why Montana ended up on the top there. I think there's probably like a remailing service that's up there, but definitely Texas, Oregon, you see quite a few of in there. Some of the more populated states there, you're seeing a lot of, and I think if I were to go out to 20, we would see some in the Washington State area. As far as maps, these are the heat map. We at 2022 we didn't really have a lot of service options in the Pacific Northwest. So then probably that probably explains why Washington or Oregon are darker of colors, as we don't do a lot of requests in that area because we don't have a whole lot of clients up in those areas. But all that being said, kind of gives you an idea of where they were across states. Now I want to take a poll, and I know you guys are some of you are on video, or some of you are on in the class in the room there. But when I was thinking about this, what I thought was, and you could tell me if I was misthinking or not. Probably everybody tells me I'm misthinking, but I imagined, or I hypothesized, that individuals with a higher income would be more on top of their records. This is my hypothesis. So I thought, hey, if you have lots of money, then you're more on top of things, you're more aware of how that is. Just kind of, do you guys think I was think that was totally off? I mean, do you understand, like, is there some, do you think there was some basis behind it? What are your thoughts? And I know it's kind of hard to interact, but what are your thoughts on that?
Yeah, I can help you field this one in the classroom. So raise your hands if you think that's true. That if you are more affluent, you have more resources, that you are more on top of your records. Raise them up high. Okay, so I'd say about half the group in here. How about online? You guys want to chime in here? So I see one person, two people. So we got 13 online. So about two people are saying they think that true. Or
okay.
three. Yeah.
Great. Well, thank you, Jonathan. Yeah. I that's not what I found. So I'll at least from the data, the points we have here. So when I'm looking at the medium income on here, and again on the right hand side, these are the really affluent individuals. We're talking about, obviously six figures, but these are those that are in the higher six figures range. The mean is, or the beginning of six figures is around right here. And obviously, not everybody, a lot of people don't make that amount. But what we saw, kind of the graph was skewed, where we saw individuals with, in some degree, the medium, or the mean was right here in the kind of the middle, which is around about 50,000 was the medium for the mean income, or the medium as far as the graph. The mean income was about 80,000 on here, but I was expecting to see more over. I was expecting to be skewed on the other side, per se, based on what we were seeing. And when I've thought about this and had conversations with others after this, because it again wasn't tracking with what I was originally thinking, there are a couple reasons for this, and I'll just kind of go through what I think. One reason was that we had, or that individuals that are more affluent probably are more educated, and so they probably have greater, they might be on top of their records more, but maybe they're the ones who are actually using the patient portal and getting the records directly, or maybe they don't have as much, they don't have as many health problems. Obviously there's a connection there between people that are financially insecure and health to some degree. So they probably don't have as many health problems. So they don't need the data as much. So you can look at it from that perspective. Or maybe the providers they go to are more boutique, and so instead of them having to hustle around, get their records and transfer them over to a provider, the provider just takes care of that themselves. So there's a lot of factors that are there that might be able to explain that. But that's kind of fascinating to what I saw. I still think and I think if we were to redo this, I think we'd kind of see maybe something similar, but we might see some differences on here. And there might be more explanations to this as well. And that's kind of what led me into the space of looking at health literacy, which is what we're going to be talking about next. So check my time. So Health literacy is, or I look at it as the ability for somebody to understand their medical records. And so with this, we it's there in if you were to, and I have there's a white paper we were able to publish on HEMA has is a journal there. I think it's the AHISP. I can't think what that stands for. They relaunched it about a year and a half ago, 2 years ago. But on the first, I think the first edition, we were able to get the paper published in there. But we had done some research in this space, and in that, we spent some time going over the background behind health literacy. There are about a half dozen measures that are used in the clinical space for understanding somebody's health literacy score. So again, health literacy, the ability for you, ideally or succinctly, the ability for somebody to understand, or a patient to understand their medical records. And these half dozen measures or tests that are used are actually they get quite, I mean, depending on which one they are, they're kind of to a point of being a little extensive, and some may argue that maybe they're kind of disconnected from what an actual patient experience is. One of them, or several of them, actually require a patient to read over a list of medical terms, and then after the third or fourth mispronunciation of that term, then the test gets stopped, and then the person scores, based on that. So if there's 20 terms on here, if they mispronounce the first three, then again they have a lower score, and that's pretty quick. There are other ones that take a little longer to do, but all that being said, I was unable to, at least in what I had access to, find good nationwide statistics of where these had actually been used. And then all of us, I'm sure, on this call know that health terms can be overly complicated. Like I'm sure most of it, if those of you that are, have done work in coding, for example, or stuff, you're looking at stuff like, how do you even pronounce it? There's a lot of that stuff that's in there, and you may understand some things, but maybe it's pronounced a little different way or whatever. So you can understand where a patient coming into this may not be able to fully understand or be able to pronounce a form. And does that mean that they can not understand medical records? I don't know. You could argue that case, but I could argue the other case where just because somebody can't pronounce the name of something doesn't mean they can't understand it. So what we instead tried to do is we wanted to look at literacy in general, because that's something, there are a lot of statistics on literacy. And so our working assumption is that if somebody can read, they're probably going to have a better chance of understanding their medical records, right? If you're able to understand just, reading, you're able to understand that too, or understand medical records to some degree, or at least be able to read those. So what we did is we looked at, we approached this from this perspective. And if you're familiar with statistics, nationwide statistics on literacy, the numbers, it varies on what what set you're looking at, but between 8th and 9th grade is generally one of the more consensus when it comes down to the ability for U.S. Individuals in the United States that speak English to understand. Most of us read about, or the average is about 8th or 9th grade reading level. There are lower ones, like if you look at individuals that are 65 and older, one of the statistics that I quote a lot of is that, and one of the statistics that are out there is that 2 out of 5 individuals 65 and older are considered functionally illiterate, which means that they have a reading level of about the 3rd grade. And if you think about, if you've worked in the health information space or work with patients, who are the folks we're dealing with mostly? 65 and older. So you can understand that. From an ROI perspective, we have patients obviously have to fill out these forms, to get access to their records. So what we thought about, we were looking at, well, are the forms that these patients are having to fill out to get access to their records, to understand their rights as a patient with regards to their medical records, are they something that the patient can understand? So we took a look at U.S. News, Newsweek's magazine, top 150 hospitals. I think it was for 2023 2023. And we went through those top 150 hospitals, and we went to their websites, found their public accessible release of information forms. They were mostly in PDF. So we took them, we converted them from PDF into Word. And then in Word, if you're familiar with it, you can go into Word and run statistics within Word. Most of you probably have already done that because you're having to count how many words there are for a paper you're having to write. 500. I teach at university too. So I know students are like that. You don't want to write more than you have to. But anyway, in that, in that same area, there's a way you can look at statistics and you can pull statistics for that. So we pulled the what's called the Flesch-Kincaid method, which gives you the actual grade level or what it presumes. And just if you're ever interested, and there's more to this, but if you're ever interested, what it's looking for is a number of multi-syllable words within a sentence. So if you have a sentence that's very basic, the boy ran down to the park. Each one of those words basically is one syllable, and there's only 7 words in that sentence or something like that. So again, that would score pretty high, or that would score pretty low as far as readability. Somebody should be able to read that maybe has a 3rd or 4th grade reading level. When you talk about some of the stuff that we have to have in these medical records request forms, like the conditioning statement, where a patient is voluntarily, the patient voluntarily signs this, that a hospital cannot condition treatment or payment upon a patient signing this release form. You get into something that's a little more complicated. And then you talk about revocation statements, where a patient has the right to revoke or cancel their, you get into this. If you've ever read through some of those forms, they could be pretty complex. So we wanted to look at that. And we thought that the top 150 hospitals, they would have the mindfulness or awareness to think about this before they put together the form, and maybe make the form easier. That was our that was kind of our hypothesis behind it. So we thought maybe, let's top 150 hospitals. We're probably going to find forms that are in the 8th or 9th grade reading level. Not so much. So in our statistics here, we only found one hospital's form is in the New York area that had a readability of less than 8th grade. It was at 7.9. So all of the other forms, though, were higher. And if you look here, the mean for this was 12.2. So think about probably all of us in this on this conference, or at this conference, where we all read a 12.2 or higher, probably, or can write even a 12.2 or higher. So imagine that. But then think about our parents or our neighbors, or the people we interact with. How many of them do you think can write at this level? Well, like I said, national statistics is about 8th grade. So you think about individuals that are older coming in, having to fill out these forms, they're probably not fully understanding the forms themselves. So I like to put that out, in perspective here, that when you're, from what we found that a lot of the forms, with the exception of one, the majority of forms were ones that were higher than what an average English-speaking American can read based on our statistics. So our, as far as discussion, or our end result here was that most of the time when you're interacting with patients, or they're having to fill out these forms, they probably don't fully understand it. So it's probably a good assumption. And if anything, if you don't remember anything from this conference, or from this presentation, other than how good I look this morning, but no, if you don't remember anything from this, remember this, that likely if you're interacting with patients, they're probably not fully understanding their rights, first off. And especially if they're filling out forms, they're probably not understanding understanding the form completely. I may not, most of us are reading faster things. We probably don't fully understand it ourselves unless we really took some time to read through. So take that out, and just remember that when you're interacting with them, that if I always encourage our release of information specialists, that when they're interacting with patients, to actually take a moment to explain the form, if they can, to the patient. So if the patient looks, glossed over look, or if they look like they're confused by something, take a moment. But I also try to encourage them that if you are interacting, you're on the receiving end of some of these forms, and you see something where the patient marked off all these things, and you're like, what was the patient think? Well, it's not, maybe they weren't fully understanding the form. That's probably a good assumption, or a good evidence-based assumption on there. So we continued on. We did a couple more studies. The second study we were looking at other patient-facing forms, or other patient-facing items. So one of those was, these are the 3 most common other ones that you come across. So consent to treat, depending on your hospital facility, notice of privacy practices. If you've never read through those, it's like reading through the terms and conditions on your new iPhone or what have you. Like, it's pages and pages of stuff generally. Some hospitals and facilities make it easier, but for the most part, that's what notice of privacy practices are. And the PHI access form. So if you're trying to sign up for your patient portal, you may have to fill out a form like that. So again, these are 3 most common patient-facing forms, not necessarily in the medical record space, but just in general, that patients have to be familiar with. And we found similar results for this too. From the top, again, same sample, top 150 hospitals from Newsweek. we're seeing, consent to treat at 13.3, notice of privacy practice 12.1, which actually I was surprised by. I would have thought that was going to be quite higher than what it was. But all that being said, and then PHI access form. So again, we're looking at these patient-facing forms for these communities where they're at a level that are much higher than what you would expect a patient to probably be able to fully understand. And I'm sorry, Jonathan, let me do time check. How much time can I have?
Yeah, so you've got roughly 10 more minutes, and then we'll
Okay.
have 5 minutes for questions.
Beautiful. All right, thanks. I just don't want to go over. So third quick study I'll talk about. We looked then, because we're releasing information, we get a lot of forms from different, we got a lot of authorization forms from different requesters. And so what we did, we took a look at our top 80 requesters, and one of those is like the state disability request form, the Social Security or SSA form, if you've seen one of those. But we took the top 80, we looked through, or we tried to access we were able to get 63 common forms. So a lot of these third-party companies that were kind of our top like PDC retrievals is one. They're kind of a third party, what we call a third party, where they work on behalf of somebody else, and so they don't have a standardized form because it's Hartford or the Midwest or MetLife Insurance or whatever that are connecting with them and they have MetLife has their own form and this and that. So anyway, we took a look at 63 of these forms, and we went through and did the same thing. We actually found that of these, the mean for these forms was a little bit lower, so 11.4. Not stellar, obviously, but a little bit lower. And I think we found there were 3, I believe, that were lower than 8th grade. So take it for what it's worth there. At least when we were looking at these requesters forms, these authorizations coming in from some of our bigger requesters, at least some of them probably spent some time to be more to make their form more digestible or readable by their by patients or the people that are filling this out. We did a fourth study, and if you happen to be at the HEMA conference last year, I had a poster there. We were the poster sessions were kind of off in the side from the main area, so I'm not sure if anybody, people only ventured over there if they got lost. But if they're doing that more. I think this is the third year. This coming year is going to be the third year where they're doing poster sessions, I believe. And so if you have an opportunity and you happen to be able to go to the conference, and I think it's San Antonio this year, if you happen to be able to go, please take a moment to go and look at those poster sessions, because there's a lot of fascinating research, and it gives you an opportunity, if you're interested in presenting some of the research you're doing or some of the stuff you're finding, to present at a national conference. So anyway, all that being said, we for this study, we looked at Spanish speakers in the United States. Now, this is a little different to approach. So obviously, Spanish is the second most spoken language in the United States. Obviously, in different pockets, there's gonna be ones that are going to be getting up there. Like the third most spoken, probably in some places, are Chinese, maybe Arabic, and some maybe depending again where you are, French in other areas. But Spanish is probably nationwide the second most common language spoken. So we wanted to look at Spanish language forms, and our expectation was that out of these top 150 hospitals, because again, best of the best, according to Newsweek, they would all have Spanish language forms accessible for people to download from the websites. Yeah, not so much. Before I get to that, though, one of the challenges we had with this study was to look at what nationwide statistics there are. So there's not really any good nationwide statistics on readability or literacy for Spanish-speaking Americans or individuals in the United States that are Spanish-speaking. There some the one that I was able to find was from the late 80s, early 90s, that said about 9th grade was what they were, and it was a small sample, so it wasn't anything we can extrapolate to the entire states, but just being aware that it was they were saying around it. So generally we kind of walked into this research with the same assumption that'd be about or similar to the readability of English speaking Americans. And again, I don't know what your thoughts are on that, but we were looking at the same. So 8th or 9th grade, we thought that was a fair way of looking at this. There was a website called SpanishReadability.com where it'll actually go through and go through about a dozen tests that are out there. So obviously Spanish is different versions of Spanish are spoken in multiple different countries. And so if you're Spain Spanish or something, they have their own readability tests. And and Spanish, and South America has the one, Spanish in Mexico. So all of them have this. So this site will actually aggregate those different. Will show you the different test ones, but then we'll aggregate it together and put it together and aggregate a score. Same thing, one grade level score of what it is. So we use that as our guide to give you perspective. And I should have shown this before. These are where the top hospitals are located. I think there's a couple up in the Washington State area, but just to give you a perspective, we found similar results. So I structured the table a little differently from the previous ones but in here is 11.8 is what we found for the readability of the Spanish language forms. What was interesting to me is I only found 120, I think it was 119 of the 150 hospitals had Spanish language forms that were accessible for me. Now, I might have not, I didn't have access to maybe their internal SharePoint or what have you. I just had access to the web, and I did for each one of those. I went through 3 or 4 different searches, looking for Espanol, looking for Spanish, looking for whatever, trying to find these forms, and I wasn't able to find them on 31 different facilities or health systems. So that's one thing that's concerning. But then even with this, you're seeing forms that are higher, or the readability is higher. So put that out there. That again, bottom line with the research in this space, at least, is that likely the individuals that you're interacting with or patients you're going to be interacting with, they probably don't have a good ability to understand or read the forms that we're having them go through. So I love this quote here: resurrect an economy but can't resurrect a person. Kind of helps to bring the topic home and leads to our final objective, which is to outline what steps that we can take to mitigate some of these factors. And so I want to get through this in time. So I'm throwing up the individual measures, or some of the main common ones that we talk about in here, just so you can go through and look at that again. Some of the ways that we can help, and I know that many of us on this call are probably students, so you're thinking, well, wow, what am I in this space here? But we all have the ability to impact change. Whether you work for our health system now or will in the future, you have the ability to impact change. So one of the steps is what I refer to as completion. So at the national level here, I know Centers for Medicare and Medicaid, they've kind of, or CMS, they've kind of moved away from. I believe last year they started moving away from requiring the SDOH fields being sent in. So in electronic medical record systems, there's usually these what are called SDOH fields, which are questions generally that the clinician would ask the patient about. Do you have access to food, or this, or I don't have all the questions, but kind of these questions that get to the point of, where is the person? Did the person have a place to stay? Do they have access to food? Do they, are they financially secure? To kind of ask for that. And one of the things that we found, just in general, even before these were not being required, but people don't, clinicians don't always fill those areas out. And I know that we don't have a lot of control as health information professionals with clinicians, but if we start to beat that drum, where we really need to have these filled out, it's better to give a perspective for our hospital, for our health system, to just kind of have an idea of like where people are, our patients are. That's one of the things. So if we can nudge people in the completion way of making sure that they complete that stuff is there. Reinventing the wheel with that one, I just wanted to point out the fact that there are a lot of great resources that are out there, and especially in health literacy, there's going to be a lot of areas where people have done a really good job of making forms that are readable. You can, like if you can kind of finagle from those, and you don't have to reinvent the wheel if you already have something that's pretty good. Like if they wrote a statement that's pretty good, and like, well, I can use that to some degree, or modify it a little bit to use it to that might be something to do. So just know that there are some good organizations out there, good hospitals and health systems that have done a good job on this, been very mindful. And so maybe there are ways that we can learn from them. Knowledge is power. So with this one, just making sure that we're training our individuals that are patient facing, like the admissions folks and stuff, to be able to recognize some of the warning signs, but then especially be able to refer them off. So having a sheet or some sort of reference they can refer off to is another thing. And then being creative. Some of the I don't want to get into my AI portion of this, but just be aware, creativity doesn't mean plug it into Chat GPT. I think we all know that, but thinking traditional creativity where you're actually like thinking about some stuff outside. And I promise you, depending on how you do it, I've gotten to the point where I'll try to clear my mind or read a book or focus on something else for a little bit. Like I'll think about a problem for a while and then I'll focus on something else for something. And then usually then that's when I kind of come up with some creative ideas. Sometimes that's helpful. So we have one more Slido poll. I'm sorry, Slido poll, which is what are some other ways they can individuals can help. I think we're kind of at a point where we might not have enough time, but so I'm just going to show you my references and then we'll leave some room for questions for that. So I'm open to questions. Thanks, Jonathan.
Yeah, you're welcome. Do you guys have any questions for him? Would you like to do the Slido poll just to kind of see what you guys come up with?
Yeah, absolutely.
Yeah, I'd say let's do that. Let's tap into collective knowledge here. All right, everyone's doing their thing.
Yeah, I love that. I think that's one of the things the first one where it talks about being patient on there. That's one of the things I love is I get the opportunity to provide training to our new release of it, well, to our new associates, but then the Read-to-Live information specialist. And I always talk to them because a lot of times we come into this when we're working in medical records specifically, but you think about patients as being customers, like, oh, and most of us are, good customer service. My first job was at a Walmart, those type of things. And so I know what customer service is, but the reality is they are customers to some degree, but they also are patients. And when we're interacting with them, they're probably not in the best headspace when they're coming in to get their medical records. Nobody, I always say this, but nobody comes in to get their medical records because like, I'm having a great day. Nobody does that. And so kind of reframing how we view them as being more of the patient thing is really is good. Yeah, I said being advocate, standardization, having resources easily available to patients. That's great. Let me see. I saw some questions kind of come up. Let me move that over to the other side here. Yeah, macro, micro, patient and population. That's fantastic. Active listening, empathetic. Those are great things. Leadership, feedback, and mission values. Let's see if I can actually scroll a little bit here. Standardization, speaking up, advocate at the state and federal levels. Yes. Right. Questions to engage conversation and honesty. That's another thing that even with all these statistics that we have, the other thing is the factor of pride. And so with that, you're going to have individual patients don't want to, none of us probably want to admit that we're struggling with something. So you take all these statistics worth it that understand that there's that other factor there that even if they are anonymous, they still don't want to maybe to admit to themselves that they are struggling with something here. Oh, I'm going to take care of it. So there may be these numbers may be maybe more conservative than what is reality on here. Checking your bias, really great. These are some really great things that you guys have written down. Yeah, excellent. Okay, let's see. Do we have any other questions on here?
Any last minute questions for Darin? Got a lot of head nods. So I think you did a great job. I really appreciate your time.
Yeah, thank you guys so much. I wish I could be there in person. I love coming up there, but maybe next year. So thank you guys so much for the opportunity to come and speak.
All right, take care, Darin.
All right, thank you guys.
All right, I'm going to load up the next presentation and we'll get started in about 3 minutes.